get started. Thank you for coming. This is our second to last session, and the term has just gone by. As per usual, I will give a few minutes of reflection on kind of my experience with the topic of today, which is treatment of lung cancer. And thank you for Dr. Wakely for coming to discuss this amazing topic here today. As you guys may recall, I am still on chemotherapy. I was given a combination agent, and then now I am on just pemetrexed every 3 weeks, maybe 4 weeks soon, and an oral targeted therapy. And I did bring them today because I've been collecting them just for fun. I'm on, I have 6 bottles, empty bottles, of my Tagrisso here as a little bit of a prop here. But, you know, every time I pick one up from the pharmacy, I'm like, well, that means it's still working for me, which is great. So this is 6 bottles. I'm on bottle 7, and that's honestly, I personally think, I don't know what you think, but a large part of why I can be here with you and be comfortable and be really minimally symptomatic is because just the amazing treatment that is possible today. So without further ado, going to welcome Dr. Heather Wakely, who is she's got so many titles, she can't even fit on the slide. Winston Chen and Phyllis Huang Professor of Medicine and Chief of the Division of Oncology, and probably one of the busiest people I know. So thank you for taking care of me as well. Okay, thanks.
Great, thanks. So thank you. Big thanks to Dr. Lin for even thinking of and doing this course. And I think that I remember as a medical student when we would get those rare opportunities where we would actually have, and here's a person actually living with this and living this way and thinking about it, it definitely puts a different perspective on things. So what Brian asked me to do today was not really just talk about the details of his particular disease and how we're treating it, but to sort of do a bigger step back and think about how do we treat lung cancer at all, and realizing that you know, some of these terms will be things you already know, and for some of you, you're gonna be like, I already know all that, and some of you are gonna be like, I've never heard of these things. So try to kind of keep it at a level that, I mean, also knowing that some of the folks taking this class aren't in medical training at all, right? So it's gonna be trying to keep it at a level that makes sense, and then trying to talk about how do you treat lung cancer in 30 minutes is also pretty daunting, because I can give hour-long talks on each of these specific subsets of what I'm going through today. So feel free to interrupt with questions. I always think that that's a lot better than me just standing up here and talking for 30 plus minutes. I definitely want to make sure that there is time specifically for questions after, but if I say something like, please just speak it out, raise your hand. I think it will make for a better time. Okay, and this is awesome. We never got fed lunch in medical school classes. This is awesome. Okay. All right, so these are sort of the learning objectives. And later on, there are some courses that are specifically about, you know, cancer and treatments. And so some of this, you're like, oh, I've seen that, or I will see that. Yes, but some of these objectives are the same. So just talking about staging, talking a little bit about some of the more local therapies, and then mostly talking about systemic therapies and how they're similar in difference and why we use them. All right, so overview. So this is kind of a busy slide. It's one of the few with pictures. When we talk about cancer, we talk about stage. And stage has to do with how far has the cancer spread. And that's relevant because it changes how do we treat the cancer. We know now that with solid tumors, even when we can barely see them on a scan, there are cells that have already gotten in other places. We didn't know that when I was a medical student, but we really know that now. However, the staging is still quite relevant, because if you find a cancer at stage 1, where it really looks like it's just the mass, and it hasn't grown into lymph nodes or gone anywhere else, the treatments are very different than if it's a stage 4, where you can tell just by the scans that the cancer has already escaped and gone into other places, and therefore those localized therapies won't work. And the stage 2 and the stage 3 are kind of in between, where it's going to be a combination of some localized therapy as well as some systemic therapy. For every single cancer, the staging is a little bit different. So we tried to memorize it. I think it's beyond that point now. It keeps getting more complex. But just to know that that's important, and you always want to kind of review and make sure you know the staging. So the simple version in lung is stage 1 is it's just the cancer. and it hasn't spread and it's not that big. Stage 2, it has spread into lymph nodes, but those lymph nodes are in the lung, or it's grown to be bigger. For stage 3, it's in lymph nodes that are in the center in the mediastinum. And with that, the idea of surgery becomes a bit trickier and oftentimes not really a reality. And then with stage 4, it's spread beyond just that region of the lung, right? So that's the simple version. It's far more complicated than that. And why that is relevant, as I was talking through, is, there's also a change in what's the probability of cure. And that does become harder and harder. But remember, for each individual person, for them, it's either they're going to be living many years or they're not. And there are going to be some patients diagnosed with stage 4 who live much longer than someone diagnosed with stage 1, right? Either because of the cancer or other factors. And so as you're talking with someone about prognosis and about these things, it's important never to try to be too precise because you're going to be wrong, right? It's trying to think about things in ranges and probabilities, and really in the framework of how is that person making decisions about their life and what they're doing and about their treatments, right? So this is there, but there's always that kind of fuzziness around any of these numbers. So we think about surgery for stage 1 or very focused radiation. For a stage 2, we're thinking about surgery or radiation, and often now chemotherapy, maybe immune therapy, maybe targeted therapy, and we'll talk about what all those things are. Stage 3, still sometimes surgery, but never by itself, always with some systemic treatment or radiation or both, or, so you kind of keep adding on. But when we get to stage 4, which is the sort of metastatic, we're not usually thinking that we can actually go in and remove it all with surgery or radiate it all with radiation. We need something that's going to get to all the places we don't see, so that's always the systemic therapy. But now 3 and 2 are also systemic, and that has evolved over time. Oops. All right. So when we're thinking about surgery versus radiation for those localized therapies, there are a lot of different things that go into this factor. I'm not going to really focus on this too much. I'm a medical oncologist. I'm not a radiation oncologist. I'm not a surgeon. So I didn't want to come up and talk about the nuances of surgical techniques or the nuances of radiation. But what is important to know is that when we're facing a patient who has a new diagnosis of cancer, we try to talk about them with a multidisciplinary group. And we call these our tumor boards, right? So we have surgeons and radiation oncologists and medical oncologists and pathologists and radiologists, pulmonologists, all together, now on Zoom, but used to be always in person. And we look at all the information we have about that person to kind of figure out together what's the right approach. Now, if they clearly have stage 4 disease, that's not always going to happen, right? And if they clearly have stage 1, easy for a surgeon, they won't always happen. But anything in between, we talk about it. And so these decisions about surgery or radiation are going to happen there. Okay, so now I'm going to spend the rest of the time talking about systemic therapy, which is what I actually know about more. Okay. And there's really 3. Chemotherapy has been around for a lot longer. And then we entered the era of the targeted therapy and then immune therapy. And this slide is highlighting all of, just from 2004, which is around when I started, my practice up until 2020, and has actually kept evolving. Many new things have evolved. In the past, we just had chemo. We'll talk about that. A little over 20 years ago, we had the first targeted therapies. About 10 years ago, we had the first immune therapies in solid tumors. And now we have dozens of each of these things. So again, I'm not going to read through all of this, but just to give you a sense of how rapidly things are evolving, we're now at a point where we're getting 5 to 10 new drugs every single year just for metastatic lung cancer, or, and then those come into earlier stages. When I was starting, we had about 5 or 10 drugs in total, and maybe we'd get something new every couple of years. So it just, right, exploding. All right, so I'm now going to talk a bit more about chemo. So these are this is a cell cycle. Hopefully that is familiar to many of you. And so the traditional chemotherapy is doing something to interrupt the cell cycle, usually doing something that's going to interfere with DNA replication so that it's blocking a cell from proliferating and can lead to apoptosis, right? So that's sort of how traditional chemo works. There are a lot of different ways to do that. You can have antimetabolites that are blocking certain enzymes, topoisomerases. You've got your non-specific, which are intercalating into the DNA. So a lot of different topics, and you all will, if you don't already know this, you will be learning about this at some point. This hasn't evolved as quickly recently because we kind of had figured out a lot of this already. So there aren't that many new chemotherapy drugs, but they are still critical, and they are still an important backbone for many, many, many types of cancers, solid and liquid cancers. All right, and these are just a few of those major kind of categories of how they're working and some of the drug names. And again, a list of the names. I have a slide, but I didn't put it in there of, way back when the trials of looking at no chemo or chemo for someone with metastatic disease, showing that by giving the chemotherapy, you actually do help people on average live longer and with fewer symptoms, because the cancer itself has a lot of symptoms. We worry a lot about, there are side effects from chemo. Yes. However, if someone is symptomatic from their cancer, you're actually on average going to make them feel better for a period of time, as long as that's working. Okay, and of course, then there are toxicities, and so we can hit many organ systems, neuropathies, cardiomyopathy, that's pretty rare. These are some of the rarer ones. The more often are fatigue, that's really the most common, nausea, mucositis sometimes, myelosuppression, potential for hair loss, but not every agent does all of these things, and many of the chemotherapy drugs that we have, actually people are able to live pretty active lives, and even, teach classes and take care of patients and things like that. Okay. All right, so then we'll move on to the targeted therapy. And when we think about targeted therapy, so many cancers, well, I think you all understand that for a cell to be a cancer cell, there's been some genetic change which makes it different than the normal cells, right? Most of the DNA is going to be exactly the same, but there's something that has changed. There's some mutation, some alteration, which has given the cell a growth advantage. And not just a growth advantage, but really an evasion of detection, evasion of something that, so it doesn't die when it's supposed to die, right? And then it can propagate. And so you start with a single cancer cell, which then, daughter cells, over time, they're going to be different subclones, different mutations are happening. But there's usually a root mutation that started it. When someone is developing cancer in the setting of exposure to toxins, such as smoking in the setting of lung cancer, other things, there are going to be many mutations, and it's hard to figure out what's really the culprit. But for a lot of people with lung cancer, there's often a single driver, the single gene mutation that led to the cancer. Now, we all get mutations in our cells all the time, right? You have the sun that happens. It randomly happens as you're doing all the DNA replication. We have a lot of systems in our body to recognize that, to kill those cells, but there can be escape, right? A lot of the really driver mutations happen in tyrosine kinases, because tyrosine kinases are such a key component of a lot of cellular machinery. If you get a single mutation in a tyrosine kinase, which turns it on all the time as opposed to it being regulated on and off, that can lead to cell proliferation and ways that it can evade. It can bring in angiogenesis. All sorts of things can happen. And these are some of the pathways that we talk about a lot, where you start with the tyrosine kinase, in this case it's EGF, that then leads to phosphorylation of different intracellular proteins, and then activation of RAF and MEK, and all sorts of different pathways. So again, I'm not going to quiz you on this because I have an hour to cover everything, but just to give you kind of that sense of how this fits in, and maybe you've been studying some of these, okay? So knowing that we're going after tyrosine kinases, there are a lot of different ways to do that. Many tyrosine kinases have to dimerize to be active, so you can develop antibodies to block that. You can develop antibodies that block the ligand binding, which can kind of shut it off a little bit. You can develop antibodies that suck up all the ligand, which can kind of shut down a pathway. For the tyrosine kinases that are mutated, where you've got your kinase domain is kind of turned on all the time, the best way to hit that is with small molecules that just shut off that area, right? So that's what a lot of our oral medications are, including the osimertinib. And then we also have these other drugs, newer drugs, antibody drug toxins, where you stick the chemo onto the antibody and then you can target the cancer a little bit more directly, and tyrosine kinases, but there are a lot of other proteins that are a target for that, okay? So some strategies. And now I'm going to talk about EGFR as a framework for targeted therapy, not just because it's highly relevant to this class, but it was also the first in lung cancer. And this was happening about 20 years ago, a little bit more than that now. So this is a cell surface with an EGFR molecule, tyrosine kinase, which is dimerized and kind of turned on. And then it's phosphorylating, leading to signaling cascades, gene activation, cell cycle, all that stuff. And angiogenesis, proliferation, survival advantages. So that's kind of why EGFR is important. It's very central. People recognized that there was EGFR expression in cancers, and so the first EGFR tyrosine kinase inhibitors were developed, and trials went forward, giving them to patients. And they realized that this was working like 10% of people, but it wasn't just anybody equally. It was working more often in women. It was working more often in patients with the adenocarcinoma type. And then it was especially working in people who didn't have a smoking history who had developed lung cancer. And there was a racial difference where there tended to be more people who were of Asian ancestry who were responding. And we didn't really understand why when that was first observed. So
there wasn't any sequencing of the tumor at the time, is that why, or they didn't know?
Well, we're getting there.
Okay.
We're getting there. You're breaking the story
Sorry,
up, Brian.
sorry.
Okay, good. Right, so this trial was designed, and it was designed in Asia for people who had never smoked, who had developed lung cancer. So it was Pan-Asia's trial. And it ended up being mostly women, because in Asia, demographics of who's smoking, who isn't smoking, is getting lung cancer. So this was mostly women, non-smokers, adenocarcinoma, and they were found to have metastatic lung cancer, and they were randomized to get this EGFR medication, gefitinib, or to get chemotherapy, which would have been the standard approach, and then to see, well, what happened? And the results came out, it was kind of confusing, because it looked like for the first 8 months or so, the chemo looked better, and then this other drug looked better, but those curves were crossing. And when you see crossing curve, you wonder, are there actually two different populations here, and we're not recognizing who they are? So this result came out, and at the same time, people started sequencing. And they started getting the cancers and looking at the cancers of the people who had responded on those other trials versus those who had not. And they identified, there were a couple of different groups who simultaneously found specific mutations in the EGFR gene in the tumor only, not in the germline, just in the tumor, of people who were these responders. So they went back in this trial, and this is, again, a little bit more about that. So there's a couple of the different mutations, two main ones. There are others, but those are the main ones. And they went back and they separated out the results from this trial, and they said, what about the patients who had the mutation in their tumor and those who didn't? And then the curves look like you would expect, right? If you have the mutation, the EGFR drug is better. These are what we call progression-free survival curves. So it's how long before the cancer grows, right? So the green is the gefitinib, the EGFR drug, so better if you have a mutation. But if you don't have the mutation, even though you're a person who has never smoked and you're a woman who's developed lung cancer in Asia, this drug didn't work for you. Very rapid disease progression. So this started this whole idea of targeted therapy in lung cancer, where if you see this target, this EGFR mutation in the tumor, then you know to start with an EGFR drug, and that it's going to be better than the chemotherapy. Okay? So 25% of lung cancer overall, but it's 60 to 70% of women in Asia or of Asian ancestry who have never smoked. Also in men, but a little bit less prevalent in men than in women. But it can be any ethnic group, people who do have a smoking history or don't. We can't tell just by looking at the person. We have to look in the cancer. And this is another trial showing that EGFR targeted therapy is better than chemo when there's an EGFR mutation. Then newer drugs developed. So this is the osimertinib drug, the Tagrisso that Bryant mentioned, so Dr. Lin. And this was comparing the osimertinib to the older EGFR drugs, showing it was actually better. And so this has become the first-line standard where it's available. Now we can have a whole other talk about global availability of different drugs and all of that, which I will not go into. But in the US, this is what we would do. It's the standard. But cancer cells continue to evolve, right?
So
with
Why do you think osimertinib is better than the other drugs?
It is effective against the most common resistance mutation that was happening with the other ones.
I see.
So with the first generation drugs, a new mutation would develop called T790M, which would block them. This actually works against that. And so that first mechanism that was the most common to pop up is kind of there. That doesn't happen. And so other things have to happen, which usually take a little bit longer. So that's why. Yeah. All right. And this is sort of talking about the fact that you know, cancer's growing, you give the osimertinib, cells die, but there's still some that persist as they evolve with each cell cycle. Every time you've got a new group of DNA, you've got a potential for a resistance mutation. If one develops, boom, that takes off and the cancer has become resistant, right? And we've tried to figure out what are those resistance mechanisms. That's another hour plus of discussion. But the T790M was the simple one with the first generations. The resistance to osimertinib is like many different things. There's not one different pathway that's the predominant one. Okay, and these are just some of the resistance pathways. So you can get bypass pathways that become elevated. You can get specific other mutations in EGFR. Again, this is many talks can be given about what happens and why it stops working. But it does happen. And then we realized that, well, if there's this EGFR mutation, what about other cancers? And so there are many other driver mutations. There are at least 12 that I have to think about when I have a patient coming to see me with newly diagnosed cancer. So the EGFR was the first. That's why I told you that story. ALK was the second. And then these are some of the others. Most of these have specific drugs that I can now prescribe that will specifically shut down that pathway if we find that that's where there's a mutation that's led to activation of the pathway. It's a little bit different by ethnicity. Some of these are about the same. Some of them vary, and I realize this is just two different groups. There's many studies looking across groups. It turns out that Latinx population has a lot of EGFR, not quite as much as an Asian population, but more than a purely Caucasian population. But again, highly variable. In my clinic, when I think about my patients who have EGFR mutated lung cancer, there are many different ways that those folks look, right? So a lot of different backgrounds. But this is just to give you that concept of targeted therapy. And this is a waterfall plot. So this is how likely the tumor is going to shrink with one of the ALK drugs for that ALK mutation. And this was the second drug. This was developed differently because when this drug was developed, we knew that this drug could work against ALK. And so in the first trials with it, they didn't, like anybody with cancer, they said only people whose tumor has this ALK change can go on the trial. And so in the very first trial of this drug, most of the patients had their tumor shrink because they knew to look for the target. So that's how we think about it now. And this is again showing where are we today with, if you find any of these driver mutations in the tumor, these are all of the different drugs that we have available now. And that literally is changing all the time. Just keeps growing and growing and growing and growing and growing. And for many of these, if we find it, we know to start with these drugs. Sometimes they're actually not better than chemo, but they're a good thing that we can use later. And then we think about combining them in different ways as well. Okay, so now so we talked about chemo a little bit. We talked about targeted therapy a lot. I'm going to talk about immune therapy as well. Any questions on the targeted though? So immunotherapy, this is your immunotherapy 101, right? So you have your tumor cell, which you want to get your immune system to recognize. You've got your antigen presenting cell, dendritic cell. You've got your immune cells, T cell, right? This again is many hours. This is full courses on immunotherapy, okay? So this is like the super simple version. You get your tumor antigens, your dendritic cell recognizes it. It presents it to your T cell. It activates your T cell. And then that goes and kills the tumor. One of the key regulators, though, is PD-L1 and PD-1. This is one of the negative regulators, right? And so a lot of tumor cells, a lot of normal cells have PD-L1 expression to say, I'm normal, normie. Tumors have this PD-1 receptor. And so if PD-1 and PD-L1 interact, that actually shuts down the T cell response. And it says, oh, never mind, that's normal. I'm going to go away. So in lung cancer and other solid tumors, there was a lot of thought around, well, maybe if we block this so that you can't get that interaction, then the T cell will better recognize the cancer, right? That was the thought. And I actually, when I was a medical student, I remember having these discussions like, hey, what if we shut that one down? Would that make it different? You know, talking with different folks. And these were ideas, but they were years off, years off. And there are, of course, other signals that are important, right? We've got our activating signals and our inhibiting signals, and this is like a small fraction of them. But in clinical practice, the PD-1 pathway and the CTLA-4 are the ones that we're using the most. And we've done lots of work in developing these others. LAG-3 is approved in melanoma, but most of them, it's just not been as quite as productive as we thought it would be by now. Okay, so this is a lung cancer trial where for patients who had tumors with that PD-L1 expression high, right? So we talked about that importance. It's not quite like a target. It's not like the targeted therapies where it's there or not, and it works or not. PD-L1 expression is variable, but in general, if the tumor has more PD-L1 expression, these drugs are more likely to work. So in patients with tumors with very high PD-L1 expression, there is this trial to look at a PD-L1 drug, pembrolizumab, versus chemo. And that, again, remember, this is the, I think this is an overall survival, actually. You can see that for patients who were getting the PD-L1 drug, they were doing much better than the people starting with the chemo, right? So very effective. And this has become a standard. If your tumor has high PD-L1 expression, you don't need the chemo. You can just get the PD-L1 drug, which has not always no toxicity, but it has different toxicities. And this is sort of showing how important it is to look at the PD-L1. This is a different trial that had patients with tumors with not just super high, but any level, showing that if your tumor had high levels, you were better off getting the PD-L1 drug than chemo. But if you had low levels, the chemo was a lot better initially, but then in the longer term follow-up, it was good that you were getting the immune therapy. And so in general, when I have a patient who comes in to see me, we need to ask, you know, find out about their cancer. Are there any of these mutations? What's the PD-L1 level? If there's a mutation that's actionable, that's more important. If there's not, then the PD-L1 level becomes important. But it's more complicated than that, right? So if you have high PD-L1 and you have a driver mutation, the driver mutation wins, ignore the PD-L1. That actually, there's nuances to the PD-L1 where it's not as relevant in some cases. And of course, then side effects. I didn't talk about targeted therapy side effects because they're all over the place with the different drugs. It could be rash, it could be diarrhea, it could be almost anything. They're all different because the kinase domain is quite variable, and different tyrosine kinase inhibitors hit various different kinases, and so you can have hair color changes, rash, neurological symptoms, vision changes, it's just anything. So it was too much to go into all that. With the immune therapy, though, you got to think pretty much any organ can be impacted, right? So you're taking away the negative regulator with PD-1, PD-L1. When that's gone, then the immune system can be confused and recognize self as abnormal and attack. And so it can be skin, it can be gut, it can be every organ. And I've seen toxicity in pretty much every organ at this point. So you have to be alert for that and warn patients. And then fortunately, steroids usually will reduce the toxicity. Okay, so we talked about targeted, we talked about chemo, we talked about immune therapy. What about putting them together? Yes, we could do that for most of it. So chemo plus immune therapy, this was a study for patients with tumors, no driver mutation, regardless of PD-L1 expression, and they got chemo or chemo plus immune therapy, and the chemo plus immune therapy was better. There was a lot of fear that if we gave them chemo, then you were going to reduce the immune response and then the immune therapy wasn't going to work. But turned out they're actually quite additive, quite synergistic, and so many, many patients will start with both, okay? That's kind of a standard. This is the FLORA-2 trial. So this was, what about targeted therapy and chemotherapy? So this was osimertinib, the Tagrisso, that EGFR pill, plus chemo, or just the osimertinib pill by itself, which had been the standard. And we looked at a lot of different things, because you have to remember, if you start with everything together versus doing it sequentially, you want to make sure that you don't look at just everything together without looking at, well, what if you gave them one and then the second one, right? 1 plus 2 or 1 then 2. You shouldn't just look at 1 plus 2 versus 1. You need to look at 1 plus 2 versus 1 and then 2 to get really a sense of things. Or you look at overall survival. So for this trial, the progression-free survival 2, which is the 1 plus 2 compared to 1 and then 2, favors the 1 plus 2 together, right, the combination. And then overall survival, it's still a little bit early, but favoring the combination. And so this has become something we don't always do because you bring in the toxicities of both. but it's something we will often do now. Okay. All right. The one thing we don't combine, targeted therapy and immune therapy. And we don't do that because the toxicities have been horrendous. Liver toxicity, pneumonitis. You would think, well, the targeted therapies seem like they're less toxic than chemo, but when you try to combine them with immune therapy, it doesn't really seem to be additive for a couple reasons. One, if your tumor is responsive to targeted therapy, it's often not responsive to immune therapy because it often is a little bit more like self than the tumors that develop in the setting of lots of toxins, like smoking. So it's not too effective, and you also get this added toxicity. So chemo is good with targeted therapy, chemo is good with immune therapy, but immune therapy and targeted therapy together are not something that we would do very often. Okay, good. All right, so that was all metastatic, right? What about when we bring in the surgery and the radiation and all of those things? I mentioned it a little bit. I will not go into too much detail because I want you guys time for questions. But this trial is very famous because it took patients who had stage 3. Remember, stage 3 is when the cancer had spread into the central part of the chest and the mediastinum. You can't really do surgery very well when that's extensive. So it was chemotherapy and radiation, standard for many, many years. But they gave chemotherapy, radiation, and then afterwards, they gave an immune therapy drug, one of the PD-1 drugs, PD-L1. And it showed a significant improvement in both progression time as well as overall survival. So that became a standard. And then there's a lot of rationale for using the immune therapy for patients who are going to go to surgery. The cancer's there. You can get an immune response going against it, against any residual cells that might be there, and then you take the cancer out. So a lot of rationalization for that. We've also looked at giving both targeted therapies and immune therapies after surgery. And that has also shown significant impacts in outcomes. So now we have to think about, okay, what mutations in the tumor, what's the PD-L1 level, not just for metastatic, but also for early stage. And then we have the tumor board where we meet with everybody and decide, okay, what makes the most sense for the patient. So this is one of the trials that was looking at, okay, patient has surgery, and then if they have EGFR mutation, they get an EGFR drug. If they have ALK, they get an ALK drug. If they don't, then they get immune therapy, right? And so this is one of the trial designs. This is the trial that used the osimertinib for patients with EGFR mutation after surgery. And this showed significant improvements in the time till the cancer came back and also in overall survival. So if someone is found to have early stage cancer, they go through surgery, it has an EGFR mutation, we'll give the osimertinib drug. Lots of discussions about for how long. This is another trial, so that's targeted. We did the same trial with ALK as we did, same positive result, we give the targeted medication. This is for patients, no mutation in the tumor that we can find. They, regardless of the level of the PD-L1, patients were going to get, that didn't work very well. They get chemotherapy alone before the surgery, or they get chemotherapy plus immune therapy before the surgery, and then more immune therapy. We've had 5 trials doing that with the different drugs. Like I said, in the past, we would have like one new drug, and now we have all these new drugs, and so we end up duplicating trials, which is a whole other talk as well. But this is one of the studies. This is another one of the trials, which I got to be involved in, where patients got chemotherapy and immune therapy before surgery, and then afterwards, they got more immune therapy versus not getting the immune therapy. And that showed actually a significant improvement in overall survival. So this is one of the standards. Okay, so how do we test for all these things? Well, you need tissue. So we try to get biopsies, needle biopsies, bronchoscopy. You also can test now from blood circulating tumor DNA. And so these are things that we're doing for patients before we start treatment to really understand the tumor. You still need the tissue to look for the PD-L1 levels. And so we're looking for, is there a mutation or not? What's the PD-L1 level? And those are really important pieces of information in addition to, is it adeno or squamous, before we figure out what we're going to do and stage, right? So we need stage, we need driver mutations, we need PD-L1 levels in order to decide what's the best thing to do. And if the patient's super sick and you don't have time to get that back, you've still got chemo, because that's going to work regardless about those things. Right? Okay. All right, so non-small cell lung cancer, how do we think about it? We do this is assuming metastatic, squamous, non-squamous. Adenocarcinoma, if there's a driver mutation, we use targeted. If there's none, we look at PD-L1. If it's high, we can give immune therapy alone, or with chemo. If it's low, we give chemo and immune therapy. If it's squamous, it's unlikely there's a driver mutation, so then we're just looking at the PD-L1.
Why do you think that there's still benefit to immunotherapy in the kind of less than 50% group? The 1 to 49% PD-L1 group,
I think that especially in combination with chemotherapy, yes. We actually just completed a trial in the cooperative group that was for patients with 1 to 100% PD-L1 expression, and they were randomized to get immune therapy alone, to get chemotherapy with immune therapy, or to get immune therapy that was then continued when their cancer started to grow, right? So it's asking that question. How much does, it doesn't really ask that, would you need the immune therapy at all? We kind of already showed that with the study I showed you before, but it's asking, do we want to continue it? It's either working or not, and then you stop it. Is it better with the chemo or without the chemo in those different subpopulations? So we're still trying to answer some of those questions, but yeah. Okay, and then small cell, I know, I'm almost there. So small cell is the other type of lung cancer, which I'm not really focusing on as much, but this is, it's a neuroendocrine tumor, so it behaves quite differently than the adenos and squamous. But essentially same things, other than it's very rarely localized, so we almost never do surgery. So it's either you can get it all under a radiation field or not, and then we're doing chemotherapy and immune therapy. It doesn't usually have a target. But there's sort of some targets and some other new immune therapy happening in bispecifics, but again, we don't have time today. So to conclude, chemotherapy, immunotherapy, molecular targeted therapies are all important, except for like stage 1. But you're not going to be doing immune therapy and targeted therapy together. It's kind of one or the other, and maybe you can avoid the chemo for a while. It's critical to test for the driver mutations and to look at the PD-L1 levels. Immunotherapy and targeted therapies are now also used for earlier stages, and as long as as radiation and the surgery, one of those are also being thought about. And then small cell is very chemo responsive, and immune therapy does seem to help. And so then this is just to bring you back to those different stages and sort of to summarize again what we've been talking about and how we kind of put a framework together on treating lung cancer. Okay, and that's it. So. You guys all ready to join me in clinic now? No? Okay.
Oh, question?
Thanks for the talk. Super cool.
I see Richard sprinting, yeah, okay.
My question was, you were talking about at the start of your career, you had maybe like 5 to 10 options to choose from to treat lung cancer, and now you have 5 to 10 drugs coming out every year. How has like the clinical trial landscape and academic institutions like evolved to handle that increased like volume of clinical trials?
Mm-hmm. Good question. So we obviously can't open every trial, right? So you spend time thinking about who are the patients who are here, right? I can't open the same trials here that someone who's practicing in North Carolina or Georgia is going to open, because the people who live around us are different, right? The people who could become the patients, right? There's different ethnic backgrounds, there's different smoking habits. When we're talking about lung cancer, that's still a very important component of it. And so if I open a trial that's for patients who have a heavy smoking history and have high PD-L1 expression, I'm going to see someone like that very rarely. But if I open a patient for someone who has developed lung cancer in the setting of never having smoked a cigarette in their life, those are the patients I see. If someone in Georgia opened a trial like that, it's much, much less. And so we have just different demographics. So you think about who are the patients I see, and I want to have the trials available for as many of them as I possibly can. And then you think about the bandwidth of like your team, right? Because when you put someone on clinical trial, there's a different level of detail that you're going to have to get from them as far as side effects. Obviously, you're always trying to help and manage any side effects, but you're capturing it in a different way, going into databases, you're coding it, you're doing all these different things. You have to really be strict about how frequently they're coming in. There are different frameworks around that. And so it's an effort, and you have a whole team then of clinical trial coordinators, but there's only so much that they can do. So you kind of have to make all of those decisions with your team to decide how many trials you're going to open. But you also have to then stay aware of what's happening all around the world. And so that's part of the fun of academics, right, is that you have to keep up with it. So you have to go to the conferences. You can just stay at home and read everything, but it's very different to hear it presented. You remember it in a different way. You can talk to people, and also can then, what do you think, how do they really do? You know, you can have those extra conversations. And so I get to go all over the world, going to these conferences, sharing the presentations from the trials we've been a part of, but also learning from other people. And then there's a lot of online frameworks, right? There's guidelines, which are put out by the NCCN, which is the National Comprehensive Cancer Network. We tend to write them. I don't look at those too often, but they're a very helpful framework for helping other people stay up to date about it. Because I only treat lung cancer, thymic cancers, and very, very rarely mesothelioma, my job is to stay right on top of all of that and know it. It's very hard for people working in a community practice where they have to know everything about everything, right? And then that's another, like, the kind of information overload. And then how do you really tell, right? We didn't need to do the same trial 5 times to prove that immune therapy is helpful in early stage lung cancer. It would have been much better if we'd done the trials to ask, well, how much does that extra year add or not, right? How do we pick who's really benefiting and who isn't, because everybody's at risk for toxicity? And so we're struggling a little bit with how do we do the right trials versus just every pharmaceutical company saying, well, I'm going to get my drug in there too, so I'm going to do the same study again. So these are kind of the big meta questions, right? So, yeah.
Thank you so much for the talk. I have a question about, from patients with low health literacy.
Mm-hmm.
Like, so many different treatment and different drugs.
Mm-hmm.
How would you approach the conversation about treatment
Mm-hmm.
with those types of patients?
So another great question. I think that it's really important to try to have a conversation at a level that is understandable for the person you're talking to, right? And so everything I went through here, you can spend more time, and you don't need to go through the entire part of it. You can sort of focus in on that particular person and the disease that they have, and then to explain it in a way that they understand. And that is something that involves a lot of back and forth discussion. It's checking in, you say something, you try to find analogies, you check in with them about what they're hearing. Sometimes it's helpful if they have family members who can work with them. And then it's sort of going back and forth, right? Because there are still some patients who come in and say, I want you to decide. And I'm okay with that as long as I know that they've understood some of it, right? And they especially know what the risks are. There are other patients who come in and they've gotten through like this many pages off the internet, most of which are totally irrelevant, but they want you to kind of explain it, right? And so trying to figure out how to communicate with them versus the person who doesn't have the education doesn't even know about cells, right? So that's one of the joys of being a physician, is sort of figuring out how to communicate in a way that everybody can understand you as you go through it. And then with them deciding how much they want to be the one making the decision, how much they want you to be the one making the decision. I think what's hard is when they come in with false information, right? Or they come in with information that that somebody has told them, and this and that happened to my aunt and they did this. And so I try to just approach that head on. As I don't know what specifically happened here, but this is what I do know, why I think that maybe isn't quite what you've heard, and it's important not to negate it. Comes in a lot too where people have alternative therapy, treatments that they want to try. And with that, it's about an open-mindedness. Like, I don't know, and I'm open with them about that. And usually open to them trying things unless there's a risk for harm. So that's where I come in and say, I'm actually worried about this for these reasons. It could hurt your liver, it could do this, it could interfere with what we're doing. Or I don't know as much about that, I'm open to you trying it, but maybe you try it, let's start this, and then you could add that in a little bit later so we aren't getting confused about what's causing what problem, right?
Thank you. went with Dr. Lin?
Sure. Yeah, I don't know how much you've shared about your.
Yeah, everything, but
Okay.
yeah, they may not have remembered it. That's
Okay,
a different matter.
right,
Yeah.
okay. Right. So when Dr. Lin came to meet me with his disease, he was symptomatic, having a lot of cough, just not feeling very well, and we had scans showing that his cancer had spread pretty extensively. We also fairly quickly got the result back that his tumor had the EGFR mutation. And so we were able to talk about the fact that in the setting of an EGFR mutation, that piece of information is the most critical, and we know we need to start on an EGFR targeted therapy. Then the decision is if we add something else to it. And because of how symptomatic he was and because there was such a high disease burden, that's why we ended up doing the combination based on that trial that I showed you the results of. Now, obviously, as a highly educated physician, these were very quick conversations because he already had a lot of the information, but it was about weighing, the osimertinib really wasn't a decision because it was, yes, you have to do that. I think the decision about the chemo was one that we did talk about side effects, what are the pros and cons, how much is it likely to help, to then decide that together. It doesn't in EGFR. It doesn't work very well in EGFR. Yeah, and it actually, if you combine immunotherapy with osimertinib, there's a very high rate of lung inflammation, which can be quite symptomatic. So, yeah.
It's exciting to see the amount of innovation that's happened in the past 10 years. What are you most excited about in the next 5 to 10 years relative to the research that is underway currently?
Great question. A couple different things. So when we think about treatment of cancer, there's a whole spectrum of it, right? Obviously, what we'd like to do is stop it from happening. And so prevention research is important. But in order to prevent, you have to understand why. And for people who are getting this EGFR type of lung cancer and other types in the setting where there isn't a known risk, trying to understand that is really important. So we're doing a trial called the FANS trial, which is in women, so you weren't part of that, but for women of Asian ancestry who develop lung cancer who have never smoked. And it's a case control trial with others who are otherwise matched but don't have the lung cancer, seeing if we can figure out what are the differences in exposure. It's a very detailed questionnaire. Are there any genetic predispositions that others have missed because people have been looking for that? So you try to stop it from happening, and you have to figure out the why. Then there's a lot of screening, right? Trying to find it earlier. And there's research in screening for people with a smoking history, but that's still not widely utilized. For people who don't have a smoking history, trying to figure out who's at risk and should be getting screened. There's been work done in Taiwan especially, but not as much here, so we're going to be thinking about that. And then from a treatment perspective, targeted therapies keep evolving, but it was like this, and now it's kind of like that. Chemotherapy is helpful, but it's not going to be revolutionary. We're trying to get new chemotherapy drugs that are more targeted, but it's like you're helping for a period of time, and that's great because you're giving people that time, but you're not eradicating. To really eradicate, I think we need newer immune approaches. And the PD-1, PD-L1 checkpoint inhibitors, that's great. It's tremendously helpful. And about 10% of patients now are living without treatment 5+ years longer, right? But it's not everybody, and it's not the patients with the targetable mutations for the most part. And so trying to get the immune treatment approaches working there, thinking about other types of immune therapy approaches like cellular therapy, that's where I'm sort of looking as well. So it's a lot.
So there's another question over here somewhere. Okay. Yeah. We have one more last question.
Hi, thank you so much for your talk. I'm an undergrad and I learned a lot. I was wondering if there's a difference between quality of life for patients who have or who receive the targeted therapies versus the immunotherapies, and then that compared to combination or chemo or
Yeah, great question. So I did try to talk about the toxicities a little bit. I didn't focus as much directly on quality of life. Again, only 30 minutes. So quality of life is multiple different factors, right? And so you have symptoms from the cancer, which may or may not be there at different levels, right? And then you've got the specific side effects from the treatments. And all of those things are quite individually variable. If you look on average, targeted therapies are less toxic than chemotherapy. But I've certainly had patients who are like, are you even giving me anything on the chemotherapy? And those on targeted therapy who are absolutely miserable, can't take it at all, right? And same with immune therapy. Some patients are like, that was great, I feel better, my symptoms are better, I don't have any side effects. And others where they've ended up with multiple different organs severely impacted to a point where they're telling me they would rather have the cancer still active than be dealing with this, right? And so there's this huge range of things, but on average, more people have more side effects with chemo, but it's kind of an up and down thing. Targeted therapy, less, but it's an all the time thing. And immune therapy, less, but if it happens, it can be lifelong, forever, and tough, right? So.
I'll take the privilege of the last question. Asking for a friend. Say in 2 years, this friend has resistance, develops, their cancer develops resistance to osimertinib. What do you think's on tap? What are things kind of on the horizon for people who develop mutations to osimertinib?
So we do additional molecular testing at that point to figure out how the tumor has evolved. So are there other pathways that have come into play? Are there mutations within the EGFR gene? Are there other resistance mechanisms that we can specifically go after? MET is one that we look for, that we have specific things we can do. In the absence of that, then we think about other newer therapies. So there's the EGFR antibody, combined EGFR and MET antibody that's been recently approved, amivantamab, which we give with the different EGFR drugs.
Lazertinib.
That's a lazertinib and amivantamab. The pertuzumab deruxtecan will likely be approved by then, so that's the HER3 ADC. And then we're still working on some of those novel immune approaches, so yeah.
Any cell-based therapy or
Yeah,
no,
that's
too
the
far away?
immune-based stuff.
Okay.
But those are still
further
very difficult treatments to go through.
We're solid, yeah.
Yeah. But yeah, we're thinking about it. We're looking at it.
Not
We're
as
building
much-
our cell therapy program here for solid tumor. Yeah.
Great.
Yeah.
Well, thank you so much for
Yeah.
your time today, really.
Great. Thanks.
Amazing.
Thank you.
Great.
Thanks for having me. So.
And just a reminder, of course, Thanksgiving next week, so no class.